Thank you for joining us this afternoon for our research roundtable with Dr. Arvin Garg. Thank you for joining us for the quarterly series. If you could just take a moment to please introduce yourself in the chat, your name, where you're signing on from, your pronouns if you prefer, and what brought you here today. That would be great. And then we'll get started in a minute or two. Hi, Dr. Siegel. Thank you for joining us.
Hi, Dr. Siegel. What a
Hi,
welcome.
so I'm Ben Siegel. I'm a friend of Arvin's.
He was my teacher. Taught me everything about pediatrics when I was a med student. Inspired me to do what I do.
Oh,
Oh, this is such a honor to have you here, Dr. Siegel.
thank you all for joining. Feel free to come off mute and introduce yourself while we have this minute or two. I see Sharon Rising is here. Sharon, thank you for joining us.
Right, I just have to find my buttons here. But great to be here.
Thank you for joining, Sharon.
Thanks for being here.
Hi, Ishan. Great to see you. Long time interest. That's great. Hi, Ashley. We have such a lovely group here today. I'll just have a couple of slides of intro and then we'll pass it to Dr. Garg. Friendly reminder that if you're not already a GROW.V.BABY Research Network member, we invite you to fill out the registration form. Our coordinator, Gigi, is going to drop the registration form in the chat. Just takes about 5 minutes. We have 2 membership levels, a general network member where you will receive seminar updates, newsletters, and other activities and offerings via email. You can participate in any of them. We also have resources and a learning community archive on our website where we have some previous seminars and blog posts from some of our network members. We have an investigator membership level where you can serve in more at a PI role in some of our research projects or participate as a co-investigator or collaborator to help sort of drive the research, the practice-based research and group care forward. We also have our 3 committees, a funding committee where we're thinking about grants and upcoming projects, applying for foundation awards and things like that. And then we have a committee that's focused on coming up with a shared definitions, shared framework for understanding group care research and practice. And then we have a committee that's focused on convening us in person, which we have been doing now a couple of years at our Vital Village Network Summit. So you can participate also in these committees. And if you sort of registered as a general network member and would like to be more involved as an investigator or collaborator or participate in these committees, please feel free to send me an email. I'll also invite Gigi to share our GROW.V.BABY email in the chat if you would like to follow up with any questions or suggestions about upcoming speakers. Here's our membership form if you wanted to snap a pic and be followed to the link directly. Also, save the date for our Vital Village Network Summit. I'll invite Dr. Boynton Jarrett, who's here to share a few words about the summit, as well as our pre-conference workshop.
Just as a small note, summit abstract and session proposal submissions are open until Wednesday at midnight of this week, and abstracts are open until the end of July for poster sessions. So there are lots of ways to participate. Should be a wonderful experience. Riviera Hotel, Boston, October 22nd and 23rd, and this will be our 13th consecutive year. So it's a really wonderful space. We have a wonderful relational health track. I think that speaks to many interests of folks here, and it's a great time to connect and become co-conspirators together.
Thank you, Renee. Without further ado, let me introduce our speaker for today, Dr. Arvin Garg, the president of Academic Pediatric Association and professor at UMass Chan Medical School, and previously was at Boston Medical Center and BU School of Medicine here with us. Dr. Garg's research focuses on advancing child health equity by addressing adverse social drivers of health within pediatric primary care, particularly for low-income families, has been cited in professional guidelines and contributes to policy change. Since 2009, Dr. Garg has been continuously funded by NIH and has also received extramural funding from private foundations. He's published many scholarly works, over 135 publications, and served on various committees focused on social determinants and community health. And we are so lucky that he's here today and eager to have a conversation with you all. And so I will pass the mic over to Dr. Arvin Garg.
Thanks, Claire. Thanks for having me. It's great to be here. I see a lot of old friends and new ones. I I think I know Dr. Siegel the longest since I was a med student, which is like 30 years plus. Have other closer friends or closer in time friends, like Renee, who was a resident in Baltimore when I was a fellow, when we started this work together. And it was fun to be with her in Boston for many years and got to know Claire over the past few years as well. And I see many other folks that I know, and I'm excited to meet new ones here as well. So I have some slides. I'm going to talk for a little bit and then hope to have a conversation and kind of learn from you all about different areas of synergy that we can think about when we think about social care, when we think about trying to address families' unmet basic needs, unmet social needs within primary care, but also thinking about group well childcare visits and how to do this in a way that is empathetic, compassionate, creates a sense, a feeling of trust and openness. And so I see a lot of potential here and excited to learn from all of you. But I'll get it going in the meantime. So, and this should be a discussion, even though I have lots of slides here, but feel free to stop me at any point. So I'm going to ground it in the definition of social determinants of health. This is a term that's kind of ubiquitous now in medicine. It wasn't something that was really mentioned about when I was a medical student. It wasn't even something that I was aware about when I started doing this work in fellowship about 20 years ago. But for the past 10, 15, maybe a little longer, I think it's become kind of part of a vocabulary in medicine, in the delivery care for healthcare systems, which is really exciting to see this kind of explosion over the past couple of decades. But the World Health Organization defines social determinants of health as the circumstances in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. And so when we think about what drives a patient's health and development or a child's health and development, we kind of think about, the care we're delivering within the healthcare system, but it's only about 20% of what really drives these outcomes. And really the rest is really related to these social determinants, these social drivers of health, socioeconomic factors, the physical environment, which is linked directly to one's income and one's socioeconomic factors, which also influence one's health behaviors and choices. And so I'm sure many of you heard this term or this colloquial saying which is true, that one zip code is a better predictor of one's health than one's genetic code. And that's absolutely true. And studies have bore that out. Over the past decade, as I mentioned, really the thoughts of trying to address social circumstances, trying to address some of the social drivers of health. People use the term health-related social needs. So I'll kind of go back in between S2H and social needs, but it's really kind of taken shape in health policy. I'd say it started in pediatrics, which makes a lot of sense, but it's spread across medicine into internal medicine, family medicine, into hospitalizations, ED visits, all the like. But for pediatricians, as many of you know, we have to think about a child's circumstances. We have to think about the child's unit within the family, within the community, the opportunities, the lack of opportunities that one has based on one's social circumstances. So it's ubiquitous. It's inherent to who we are as pediatricians, and so it's something that we've always thought about, seen with our own eyes, and it's passed on as we learn pediatrics. I was lucky enough to be a medical student at Boston Medical Center, and this is something that was really clear to me. Was a driver of a child's health and development. And if we weren't addressing this, we weren't providing complete care or really effective care for the children we take care of. So in 2016, the American Academy of Pediatrics policy statement on poverty recommended for the first time to screen for social drivers of health or social determinants of health or social needs. I'll use all these terms interchangeably at child care visits. And since then, Medicaid ACO programs and managed care organizations really kind of incentivize and really kind of prioritize social needs screening policies. So in Massachusetts, or we're part of a Medicaid ACO, and as part of that, one of the quality metrics is screening for social determinants of health. A few years ago, post-pandemic, the Joint Commission accreditation required that to get Joint Commission accreditation, at some place within the hospital, there needed to be some S2H screening that was occurring. So again, this helped to kind of accelerate this type of health pulse or health policy into healthcare delivery. And so I think it's fair to say that social needs S2H screening has become a standard of pediatric primary care now, and something that has evolved over the past decade or so. And it makes sense why we're trying to do this. The ultimate goal is to improve children's health, to decrease avoidable healthcare utilization, to improve their development. And there's different pathways that we can think of how screening within the child care visit, within the purview of a clinical visit between a physician or a clinician and family can lead to better outcomes. So first is just identifying the needs, connecting families to resources for food, for employment, for childcare, decreasing those social risks. But there's also indirect ways as well, providing emotional support, enhancing the relationship between providers and between families, providing healing to families, which can improve their emotional support. Also, health service connection pathways, increasing connectivity with healthcare services can help as well. And then tailored clinical care pathways. So if we know that a family doesn't have, heat or adequate housing, it will potentially inform the choices we make in the care delivery that we're providing to those families. And so as we think about social needs screening, I think there's a lot of important work that's happened. I think it's very exciting that it's part of routine pediatric primary care. But there's also a lot of questions that come up when we think about social needs screening that I just want to kind of call out before I kind of go into some evidence about it. So when we think about screening in the medical context, we think about screening the purpose is to try to identify as yet undiagnosed disease in individuals without signs or symptoms, right? So we're trying to screen for cancer screening. We're trying to screen for risk factors for cardiovascular disease. And so the concept and the rationale is that if we identify earlier these risk factors, it'll lead to earlier treatment. And with early treatment, we can reduce morbidity. So classic is cancer screening, right? We identified early, identify the malignancy at an earlier stage, we can reduce morbidity and mortality. But when we think about social needs screening, we're screening for social needs like housing, food, employment, childcare, heat, that patients and families are well aware of. And so we're not trying to diagnose something that that child, that family isn't aware of, or that parents aren't aware of. And additionally, it's different than medical screening, right? Because the treatments are outside the medical system. We want to connect him to the WIC office or to public benefits or to SNAP or to Section 8 housing, etc. And then when we think about social needs screening, I think there's three, in my mind, three purposes that we can derive from. One is to collect data to try to understand the prevalence of social risks. So within your clinical setting, within the clinic that you're serving, or within the hospital setting, we want to know. It might be helpful to know X% of your families are at risk for housing insecurity or at risk of food insecurity. But to be honest, we know that's highly correlated with poverty. So if you're serving low-income families, we know that many of those families will have these conditions. The second purpose is to create social risk prediction models. Potentially, if we use this data, we can predict hospitalizations, adherence rates with well childcare visits, with immunization rates as well. And the third purpose, and this is one that's kind of driven me in my career over the past couple of decades, is to try to intervene to address patients' and families' needs with the goal to try to improve healthcare outcomes, and advancing health equity. But when we think about screening for unmet social needs, we have to think about, is this scalable? Is this scalable, and is this sustainable as we do this? It's fine to have a policy statement saying we have to screen everyone, and because of that, we'll do that to achieve that quality metric, because there's a financial incentive there. But we have to think about, is it really scalable? So, for example, are there sufficient support staff to assist patients and families with needs? We could give, and I'm going to talk about some of my work. We've been on information sheets, we give out resources, information that's been successful, but it'd be really wonderful to have everyone have one-on-one help and assistance with someone who's empathetic, compassionate, who's knowledgeable about resources, who can help families navigate the labyrinth of social service agencies and the bureaucracy and the paperwork. But if we do this, we had to make sure it's scalable, right? And so this is some data that from one of my first trials, we looked at Boston. We recruited families in Boston community health centers coming for pediatric care. And we found that 90% of families had at least one of these basic needs. So for food, for housing, for employment, for education, for childcare, or utilities. Two-thirds of families that we screened, that we enrolled, had two or more needs, and almost 40% of families had three or more needs. So again, as we think about community health centers or clinics serving thousands of patients, in these clinics, over 90% of families have at least one need. So realistically, is there enough social work support, community health workers, um, patient navigators, other support staff to help every individual, every family in that clinic with that need? And I think that's something that's really hard to say yes to. It's hard to scale when the need is so great within the health setting. And the second thing is that, okay, we can do all the screening we want. We know that in certain clinics, like community health centers, the data I showed you in Boston, there's a lot of need, but are there sufficient resources to connect these families to? And, in the US, we have an insufficient and inadequate safety net that has persisted over the generations. And so when we look at public spending on families and children as a percent of GDP, when you look at our comparable countries around the world, we see that the US has the lowest investment in spending on families and children. This is despite evidence that if you invest in social spending, in social services, in social resources, and social safety net, that it actually improves health for individuals and populations, and reduce healthcare costs as well. This has been shown looking at state data as well as international data across the world. And we know, unfortunately, that needs are climbing. So this is a recent article that came out in the Boston Globe a couple months ago that currently about 40% of families in Massachusetts are food insecure, and that number keeps on going up and up. And it's not surprising because it's a downstream effect of public policies that are leading to these consequences. So as there are cuts to the social safety net, cuts to emergency food, to food pantries, to et cetera, it's not surprising to see that hunger is rising. And we know that unmet social needs, these needs related to food, related to housing, related to basic needs that a family has, is highly correlated with poverty, right? So families who are poor um, are much more likely to experience these adverse consequences, these adverse needs. And when we look at our comparable countries around the world, again, the US has the highest child poverty rate compared to other developed countries, right? So we invest the least amount in our social safety net, and we have the highest poverty rate. So given that, those two things, it's probably not surprising that many families are unable to receive the benefits and the resources they need to address these unmet material needs. And we look at child poverty rate in the US specifically, it wasn't always the case that well, let me just say that children since early 1970s, so over the past 50 years, have been the poorest segment of the population when you look at it by age. And that wasn't always the case. So it used to be the elderly in, before 1970 for generations and generations. But then during the war on poverty from Lyndon B. Johnson, the enactment of Medicare, Medicaid, thankfully, the elderly's poverty rate reduced pretty remarkably because of Medicare and Medicaid specifically. But unfortunately, we haven't had something comparable for children. And again, in our society, for the past 50 years, and there's no end in sight, unfortunately, children remain the poor segment of our population. We had an opportunity, by the way, during the pandemic, paradoxically, as many of you know, where we actually saw a drop in the child poverty rate. There's a huge investment in pandemic programs, aiding families. It was almost like this collective trauma we're all going through. And we saw many, many families who had these unmet needs, who were becoming unemployed. And there's this huge spur to invest in these programs in the short term, including the child income tax credit, which provided for families who are eligible, which were many, many families, millions and millions of families, $3,600 for one child less than five, and $3,000 annually for a child over five. And that actually reduced the child poverty rate in half for that 1 year. But because of lack of political will, because of racial stereotypes and tropes about, what families would do with the money, even though studies show that the majority of the money was spent on basic needs to address for families, after a year, that policy expired. And this was a editorial in the New York Times a couple years ago, titled "America Pulled Children Out of Poverty. Now it's set to reverse course with a vengeance." And this was a quote from one of the editorials from Dr. Matthew Desmond, who wrote the book Evicted, talking about our addiction to poverty, him stating that poverty isn't just a failure of public policy, it's a failure of public virtue. And so something that we've been thinking about a lot in the work we do, and this is in a commentary that we wrote a couple years ago, was that as we think about how we try to deliver evidence-based care to patients and families, we have to think more upstream as well. And so we wrote in this commentary, just as health systems aim to provide evidence-based medical care, they should also advocate for evidence-based social policies that promote health and health equity. And so I'm going to pivot and talk a little bit about how do we think about integrating effective, empathetic social care into pediatric healthcare. I'm going to talk briefly about some of the research we've done in the space. I like to say this is my fellowship project that I've been doing for 20 years plus now. This was a project I titled it We Care with this acronym that states here. Renee was one of my participants in the study, and I was worried because she was in the control group that she'd screw up our findings, but despite that, we're still able to find some cool findings. And so we did a randomized control trial in Continuity Clinic in Baltimore the Harriet Lane Clinic. And we randomized clinics to this intervention where I asked families basically on a screener if they had one of 10 needs and whether they wanted help. And we provided resource books that providers would rip out an information sheet and give to a family. And then we interviewed the family right afterwards to see their experiences during the well child care visit. And we found was that the We Care social needs screening tool model increased the discussion of these needs with the provider and increased referrals from about 10% to over 50% for these adverse social drivers of health at low-income children's well child care visits. We then did a study when I moved out to Boston, um, kind of doing under more real world circumstances. So we did a study in eight health centers in Boston. It was a cluster randomized controlled trial. We did it under really controlled circumstances in the sense that our research team gave out the screener to the families. They filled it out. The families then provided to the clinician. Clinicians had access to the resource books. They would then give out the resource sheets as well, and then we collect this data afterwards. And what we found was that first index visit in the community health centers in Boston and these eight clinics, four randomized to the We Care intervention, that compared to the usual care group, 70% of families received a referral and information sheet compared to 7% in the usual care group. So again, you can see the need was great, and we're able to identify families who wanted help with these needs at the visit. We enrolled children from birth to 6 months, so infants. We followed them till a year of age, and we found that at that time period, almost 40% of families enrolled in a new resource, like a food pantry, a SNAP benefit, or a WIC benefit. When we think about food, but across all these various domains, compared to about 24% in the usual care group. So, it wasn't like our families who weren't being exposed to our intervention didn't get resources. They did, but those who were exposed to our intervention got resources at a much higher rate. And so just kind of summarizing the evidence base for social needs screening and referral systems at well child care visits. Our studies have shown that it can increase referrals and receipt of resources, especially when we do studies under really controlled conditions, when we make sure that the survey, a screener was completed, and we make sure that families received information sheet. In some of our subsequent studies, we found that this model has increased immunization adherence rates. It's improved parental reported child health in some other studies done by Laura Gottlieb and her team. But in some of our more recent studies, one we published a couple years ago, one that we're going to publish in Pediatrics in August, we found mixed results regarding child maltreatment rates. There was no difference. ED visits and hospitalizations. We actually found more ED visits and hospitalizations in our We Care group. This was detailed in our paper in Pediatrics in 2023. And we found no difference in receipt of resources 3 months post-visit, post-screening, under really real-world conditions. And so, the evidence, I think, is still kind of mixed, that under controlled conditions, the potential is great. But under real-world conditions, it doesn't always hold up as much. And we have to think about some of the ways we can make sure it works well, effectively, and equitably for families in the real world. And so that's what I'm going to talk about a little bit now. So think about We Care under real world conditions. So one of our studies that we had done a couple years ago, we did again in community health centers. We made a standard of care. And so the research team trained staff to give out screeners at well child care visits as part of routine care. They had a way to provide resources through the EHR or resource books. We found that only about 30% of visits had a We Care screener documented. So, some visits had the screener probably, it just wasn't ever documented. But there are probably many visits that the screener was just not given out at that visit. We found that over 40% of families received resource referrals at a well child care visit in the first 3 years of a child's life. So this was documented in the EHR. We had a system where if they sent a resource sheet through It was Centrex initially, and then Epic. It was collected and captured in that visit, so it's not related to providers' documentation. But we found that only 40% of we care families received it. Remember that we did this under controlled conditions where we had a research team give out the resource sheet or give out the screener. We trained providers to give out the resource sheet from the resource books, and that was 70% at that first visit. But under real world conditions, we only found a little over 40%, not only the first visit, but the first 3 years of that child's life. And we found that almost 40% of, or over 40% of parents who asked for help on the We Care screener, because our screener used to ask, for employment, do you have a job? Yes, no. And then if no, do you want help? So, we feel like everyone who says they want help should get something, should get a resource sheet. They're basically, a family is bringing that need to you saying, I want help, help me. But we found that over 40% of these families who asked for help on the screener did not get a referral. And that's been called double loss. I'm going to talk more about this here. And so with double loss it has been documented and has been contextualized. It means that parents and families are disclosing sensitive information without getting help, which frustrates them. So the parents have framed the disclosure of a social need, like not having enough food for their family, as one loss, but then not getting help from the provider after they disclose it as a second loss. And the parents didn't just want to talk it out with their pediatrician, but they also wanted to get assistance, particularly when they tell their pediatrician that they want help. And when we looked at our data more closely, this was during the pandemic, we realized that there was a racial and ethnic difference. So Asian and Vietnamese speaking parents in Boston who attended community health centers had higher odds for double loss. So almost 2/3 of them who reported on the screener, I want help, didn't get help. And that parents who experienced double loss had significantly lower well childcare visits and immunization adherence rates compared to those who didn't experience that. We wrote this up last year in academic pediatrics as well. And so this is a quote. I think, like, sometimes the data is the data, but hearing quotes, I think, can make it feel even more impactful and powerful. So this is a quote from one of our Latina patients. We've been doing more qualitative work, which I'm going to talk about in a second. Well, sometimes I think that people are already afraid. Sometimes people believe that they fill out the form and the help won't come or they won't get help. And then sometimes people say they get tired of doing that, doing this, doing that, and not receiving support. And truthfully, help is needed. If you have at least 2 or 3 months without paying rent, you fill out a form. So I filled it out, but that form I never saw the benefit or anything like that. I never saw the help. People think they will be fooled. You feel bad. You don't believe anymore. You think that they're messing with you or that they are playing with you. So it can't be like that because everyone who fills something out is because they need it. So again, having this concept of double loss, having families courageously share that their needs with us, and we don't even acknowledge it or provide any support or even comfort, can lead to really hurt feelings and feelings of mistrust, further mistrust in the healthcare system. And so we wrote this commentary thinking about that. It's great that these health policies are here. It's great that it's been accelerating the need to do screening within the healthcare systems. But unfortunately and paradoxically, it has the potential to increase racial and socioeconomic inequities, even though the much of the genesis of this, much of the efforts of this is to reduce inequities and to advance equity. Um, and so when we think about, again, poverty in the US, as I mentioned before, children in the poor segment of the population, but not all children are poor equally. And so Black, Indigenous, and Latino, Latin children are disproportionately low income compared to white children. The rate's about twice as much in the 60 percentile versus 20% or so for white children. Um, this is something that came out in Boston a few years ago. The headline was, "That was not no typo. The median net worth of Black Bostonians really is $8." So when we think about income, we also think about wealth, right? And wealth is that generational money that families may have that really help when unexpected things happen, that aren't foreseen. The car gets broken, or opportunities that you want to help support your family to buy a house. For example, the wealth is where it really helps. And so in Boston, the household median net worth for white families was about $250,000. For U.S. Black families, it was $8. For Dominicans, it was $0. And so, again, there are racial inequities when we think about income and wealth, not only in Boston, but throughout the country. And I bring this up because as we think about social drivers of health, socially determinants of health, we know that it disproportionately affects children. We know it disproportionately affects children of color, Black and brown children. And that's not random. It's related to public policies generationally rooted in structural racism that has led to these inequities in who we care for and what needs these families have. It speaks to a darker history, a more complicated history, a really sad history related to the medical apartheid system that persists in this country. And so some of our work recently, we've been thinking about health-related social needs screening from the perspectives of those most marginalized in our society, and also those who have the most unmet basic needs in our society, namely Black and Latino, Latin patients. And so this is a study we've done with caregivers as well as patients of color. And this was a mixed method study that we had gotten published in JAMA Open a few months ago. And some themes came up from our interviews talking about unmet social needs screening that families faced. The first theme was that previous unsuccessful attempts to obtain social supports led to skepticism that needs will be met after screening. So one quote is, "They make you fail at many things that are supposed to help you, and at the end of the day, nothing happens. Promise after promise, you don't live on promises." The second theme was that patients and caregivers perceive the process of obtaining social services as unattainable, holding doubt about eligibility and linguistic accessibility. So you fill out the screening, but are you actually going to get that help that you need and deserve? The third theme was that experiences of racism and discrimination lead to distrust that systems have patients' best interests in mind. And finally, the fourth theme was that the disclosure of unmet social needs carries emotional costs, such as disappointment, frustration, and feelings of discrimination that can hinder engagement in social needs screening. And so just as we did some further work, we looked at some identified barriers to engaging in social needs screening for Latin patients. Some barriers included unsuccessful attempts to obtain social needs supports, lack of Spanish language offered support services, and encountering racism and discrimination when engaging with healthcare and or social service systems. And so again, as we think about health-related social needs screening, S2H screening, we're thinking about that interaction, that encounter within the clinical venue. But there's a much larger ecosystem that patients and families, when they come into clinic and see us, that we have to respect and understand and think about when we ask them to delve and provide some basic needs that they have that they can't provide for their families. And so this is an example of discrimination and racism that came up in one of our participants in our study. So talking about discriminatory clinical experience with a medical provider. So just because we're not from the same country, or just because I don't have green eyes, but I'm a human being, she doesn't have that human quality. So speaking about the medical provider. So she sees you like as if you're a little bug because she studied and she's in the back on the other side of where she gives the medicine. So she's better than you. That's how I felt, as if oof. So the doctor said, I'm the one in charge. I'm in charge. I'm the one who decides. I'm the one in charge here. And who are you to tell me to give you the pills? If you die, you die. If you get sick, you get sick. That's your problem. That's what I got from her. So again, we just have to think about the context of our patients. We have to think about our how we speak with our patients. I suspect this provider probably had no idea that they were coming across like this. They probably had best intentions, but this was really impactful and really hurtful experiences for her patient. And so this was a study done looking at an effective social care intervention on healthcare experiences of caregivers of hospitalized children. Basically, they wanted to see whether social care intervention screening impacted the healthcare experiences versus those who didn't. And it didn't make a difference. And they rolled over 600 families in an urban hospital, children's hospital in Chicago, mostly Black and brown families. And overall, they found that families were satisfied with the discharge, 83% or so. But when they measured discrimination, they found that half of families experienced discrimination during that hospitalization. So it's like this contrary thing, right? If we had just looked at discharge satisfaction, which is patient satisfaction is a quality metric that hospitals pay very close attention to, it looked like they were doing fine, right? But by measuring discrimination within the hospitalization, if we don't collect that information, we had no idea. But half of these families experienced it. So something we have to be really intentional about as we think about how we provide fair, equitable, compassionate care to patients and families. And so, again, hopefully, I've unfortunately convinced you that the need for us to be infusing an anti-racism lens to the work we're doing. Defined by Dr. Kamara Jones, anti-racism is a work of actively identifying and eliminating racism at the individual, institutional, and structural levels, which is often perpetuated through unexamined organizational structures and norms. And I recognize that this work is much harder in this environment right now, but nonetheless, I think it's important for us to be thinking about this during this difficult time, and probably even more important to be thinking about this right now. And so Dr. Jones's framework is to if you see racial differences in the outcomes, it's not based on race, which is, race is a social construct. It's due to racism. You have to ask how's racism operating to lead to these disparities. It's important to organize and strategize stakeholders to act as we move forward. This is a paper that from colleagues at SHOP, Deethi Vasan and George Dallenberg, thinking about how we apply an anti-racism lens to social needs interventions, thinking about the various levels of racism at the structural, institutional, interpersonal levels, and thinking about the intervention from development to assessment of risks and needs, responses, as well as connecting families to resources. Again, this is not anything new. The report on unequal treatment came out in 2003 from the Institute of Medicine. 20 years later, this is one of the headlines. 20 years ago, landmark report spotlighted systemic racism in medicine. Why is so little changed? So this is something that is really important for us to be thinking about, be cognizant about, again, despite these challenging times. The other thing we want to think about when we think about this work is thinking about the feelings that families have, sharing these needs that they have for their families and for their children. And so this was a study done by Deepak Plakshapa, when he was a fellow in Philadelphia, looking at suburban families' experiences with food insecurity screening. And he found that overall, parents were comfortable discussing food insecurity with their pediatrician. Parents expressed initial surprise at screening, they weren't expecting it, followed by comfort discussing their unmet food needs. And hopefully, as we normalize this over time, less parents will be surprised. But what they found was that, or what they told Deepak and the team was that it was important for pediatricians to clarify that screening was to offer support and to acknowledge parents' feelings of shame that accompany food insecurity. So, we have to be thinking about the shame that's associated with this, the courage that families have to share, but no parent wants to feel like they're not providing adequately for their family and for their children. And so it's one thing to look at a screener and look and say that family's in food insecure, but it's another thing to acknowledge the social stigma that parents have and the courage they have to share this really sensitive, delicate, shameful information about themselves and their family with us. And it's really a privilege for us to have that opportunity and that trust for families to do that with us. So this is a commentary that I wrote with Renee many, many years ago, thinking about how do we mitigate some of the unintended consequences of social needs screening. And I think some of the lessons here are still poignant and still timely even now. And so guiding principles, we want to ensure screening is patient and family centered. We want to integrate screening with referrals and linkage to community-based resources. So a lot of the health policies really incentivize S2H screening, but they don't really incentivize the next step of connecting families to resources. I think pediatrics has been different in that regard. I think that's most pediatric practice I'm aware of try to do both at the same time. We want to integrate shared decision making. We want to acknowledge that many families may not want to get help from us. They may not trust the clinical setting, the healthcare system, and understandably so from the generational trauma that they and their families have experienced. We want to use strength-based approach. So even though we're identifying needs and risks, we want to also acknowledge and identify strengths that every family has that they're bringing to the encounter. We want to continue to try to co-design social care programs with patients at the table, along with staff and community members. We want to ensure that staff have ongoing anti-racist and cultural humility training. And we want to incentivize healthcare systems to assist patients with social needs. So again, moving away from just screening, but also to assisting to get that financial incentive. So I'm going to just talk for a couple minutes about social needs screening group well child care visits. Um, when we think about the evidence base for group well child visits, and you guys know this much more than I do, but just for me to remember how it's kind of situated and set up, but taking a standard 15-minute well child care visit that I usually conduct in clinic and expanding it to 45 minutes to almost 2 hours with families with same age children has been shown to increase well child care visits, immunization rates adherence, parent satisfaction, and psychosocial screening completion, including S2H screening. It allows increased time to discuss social concerns and provide anticipatory guidance as well. I think there are great opportunities for social needs screening at group well child care visits. It allows providers, it allows the ability to normalize unmet social needs through peer interactions. So a family doesn't feel isolated by themselves, doesn't feel shameful that they're the only ones who have this. It requires trust across the families in those interactions, but I suspect that's one of the great strengths of group well child care visits is that ability to have peer-to-peer interactions to generate that, engender that trust and that support from one another. It reduces stigma and isolation, I believe. Again, they're not living through it themselves. There's not just this hierarchy between the provider and the family with these needs. There's multiple families, and the power dynamics, I think, can change. And allows us to provide more culturally sensitive, more culturally humble, anti-racist care by, again, elevating the voices of our families and shifting some power dynamics. So in closing, hopefully we'll have some time for some questions and dialogue. Social needs screening, for better or for worse, is part of standard pediatric primary care. Evidence to date is mixed, but it's promising. I'd say under control conditions, it works really well. Under real world conditions, it doesn't work as well, but I think there's opportunities to fix some of the implementation challenges to make it work just as well as in control conditions. Barriers include lack of resources. We think the needs are so great in certain clinical settings, lack of support staff, stigma, discrimination, and then the visit time to try to address these needs accordingly. And that group wild childcare visits is an opportunity to further study and explore new pathways to address these barriers and improve social care delivery. So with that, I'm excited to be on this journey with all of you. Thanks for your time and attention. And it's really been great to be here and let me gab for a few minutes, but I'm happy to open up to hear from all of you. Thank you so much.
That was so awesome, Arvin. You covered so much. I know we don't have too much time for questions, but I'd love to open it up to the folks that are here. In particular, would love to hear from any of those who sort of think about addressing social needs within the context of group care, who are facilitating group care, if you'd like to chime in. But I'll pause here to see if anyone has questions they'd like to enter in the chat or if they'd like to unmute. Otherwise, Renee and I have questions as well.
Thank you for all these emojis. Wow. So fancy.
Sharon stated in the chat that group visits provide the opportunity for parents to suggest possible solutions that will help other participants.
Yeah, absolutely. That's usually where we'll get the best ideas, right? It's from our parents and those who live experiences to think about and share with us their experiences and how we can improve it. So that's spot on.
So I'm going to jump in with a question. Arvin, thank you. Wonderful presentation. Pretty good one. I'm in San Diego, friend of Claire's. That's how I got here. So thanks, Claire. One of the things I'd say is that, my joke is all my pediatric colleagues believe that they play a solo sport when it's a team sport, and that you actually need a team and a village around you to support the village. And so I just wondered if you have any thoughts about that, because I think the group well child visit is part of that. But I think when you're talking about the social drivers of health and the wonderful screenings that you're doing, and the sensitivity and thoughtfulness around it, wow, what would it look like if you could pick your team to take care of your families?
Yeah, no, I think that's I think it's moving in that direction, right? So like we hear a lot more about team-based care than probably a generation ago when I was learning medicine. But I think we think about who the team is and what skills they need to have to be effective. And I think that's been I think there's some more evolution there. And where does a team live, right? Does a team live within the healthcare system? Does it live within the community setting? Does it live with support services and safety net programs?
Yeah.
Does it live in the schools when we have children, when they spend most of their time, families spend most of their time connected to the school versus the pediatrician office where they see us once a year for a wild childcare visit. So I think the team model is absolutely correct. And I think as we evolve this model, it's not just team members within pediatric primary care, but team members within like the neighborhood that children live in, families live in, to really be the most effective.
Thank you.
Thank you so much, Arvin. There's a couple more questions. Ada, I don't know if you want to unmute, but she said not about group, but have you ever tried We Care, which is the opportunity to ask for or decline help versus some of the other extant screeners, including perhaps the MAs asking whatever's in the EHR.
Yeah. So what we do at UMass is we use the social risk questions, the Common Health Community's social risk questions, and we use We Care, if that makes sense. We have like 8 questions to look at social risk around housing instability, food security, utility risk, um, and transportation. And then we asked families, do you want help? As part of the We Care group. And we actually found the rates are pretty similar between the two groups. Maybe our We Care needs are a little bit higher, but there's really little correlation between the two. So many families who you can diagnose as food insecure because they haven't had enough they're on versus a hunger on a hunger vital sign, they're food insecure. When we asked them, do you want help with food? There's no correlation. And we published a paper about that a couple years ago, looking at that. And then what's actually really interesting is that we looked at, do you want help for food? And the questions were yeah, or the answer choices were yes, no, maybe later. And then we called families like 2 weeks later saying, we have this food program where we can give you a food voucher of $60 a month for 6 months. Do you want it? There was no correlation between families saying, yes, they want help with food and accepting the food resource. So it gets really kind of like messy as we think about how to do this in a way that's most effective. But I think it speaks to the challenges and to the levels of complexity for a patient and for a family to, one, say they have a need, and two, say they want help, and three, say they want to get a specific resource. And so I think I think there's cultural variation. There's variation by other family dynamics that I think that are hard to like put it into an algorithm, for clinics to implement. Sorry,
Um,
very long-winded answer.
We are at time. I almost want to invite you back, Arvin, to have continued conversation. There are multiple questions in the chat. I think group care, like you were saying, offers a model for not only screening and identification, but like Sharon shared, the people are sharing with each other what they're actually seeing in their community. And so many resources are evolving and changing, and things happen and then they get, taken away. And so the group offers such a nice real-time opportunity to share live resources. And so we can continue to have this conversation about how to more effectively address social needs within group care. Thank you for being here. I'll pop it over to Renee for any closing last words, but this was exceptional. Thank you so much for your presentation and for your words today, Arvin.
We are saving the chat and hopefully can provide some warm connections for you, Arvin, with some of the important questions and reflections that were brought up there. This is such a powerful and thoughtful presentation, and I really appreciate how you, as a researcher, also role model a really reflective process about learning about, some of the benefits that come from interventions, but some of the potential harms and downsides that can come up, particularly if we don't fully explore the ripple effects of what it means to be heard and to be seen. And I think a lot of what you shared spoke to that, and it connects really beautifully to the centering and the group care model of strategies to help create a collective process for people being seen and heard. And I feel like the power of the question of not only what is challenging, but would you like help is a big agency shift of shifting agency to the families. And so I just think there are many lessons that I continue to learn from your work. And we so appreciate your leadership in this space and your time. And as Claire shared, we're not going to let go of you. So hopefully this will be one of many, many, many visits and, big family kitchen table. Thank you all so much for joining us today. And thank you, Arvin.
My pleasure. Thanks, everyone.
Thank you.
Have a
Take
great
care.
day. Bye.